functional MRI imaging. Give it to me. What is it?
Yeah, so functional MRI or fMRI looks at blood flow to the brain over time. And so if the individual is performing a task and we're looking at the kind of high-frequency changes in blood flow over time, we're looking at the brain areas that call blood flow to them active in that task, that are required for that task. If I'm doing a memory task, the blood will be called to metabolically active regions like the hippocampi in charge of memory performance. If I'm performing a balance task, it'll go over to motor and sensory and cerebellar areas. If I'm performing some type of vision task, the blood flow will go predominantly over to the visual cortex in the back of the brain. And so blood flow signal over time during a task is used to identify regions or groups of regions that are in charge of a function related to that task. And so it's one way to localize brain function is to do fMRI in the MRI machine during task performance. And in concussion, you can look at task performance that challenges the individual and see if the blood flow patterns are different than normal. And so, for example, if the hippocampi are supposed to light up with increased blood flow during a memory task, if they don't light up with increased blood flow or they light up more than normal people in a concussed individual or group, you would say that that region during that function, that task of memory performance, is abnormal. It's abnormally overactive or it's abnormally underactive.
Yeah.
And so that's how task-based fMRI is used.
Okay.
And it's a good tool, and it's been around since the 90s, and it is used on group-level basis in studies. It's not yet used on an individual basis unless planning a surgical resection in epilepsy or tumor surgery, where the language area, for example, eloquent cortex is needed to be located specifically in that individual. And so they will undergo an fMRI and have a language task performed, and the areas of the language network will light up. And the surgeon will then try to avoid those areas in real time, stereotaxically, during the surgery, so as to kind of remove cortex that's involved in the epilepsy or tumor, but not the key areas of the language network, because it's such an important function for humans. But other than that, fMRI is not really approved or generally used for individual subject interpretation. So you can't go to an academic center and get an fMRI and say the concussion happened.
There it is.
And there's the migraine.
There it is.
Although you can go to a community practice and get that type of interpretation. I just would be very wary about it. And we get referrals or patients who come for second opinions after getting tests like that. Or other functional tests.
Now, it's difficult. It's the reason that it's not instituted as standard of care right now is because there's not normalized data. Is that right? Where you can't say, hey, if this doesn't light up on the fMRI, then it means that you're still having concussion symptoms. Like, it doesn't really translate necessarily to your symptoms, where you could say, hey, if this is fixed, then all your symptoms are going to get better.
Yeah, I think the reason it doesn't translate to individual subject interpretation or diagnosis is because there is variability in this signal, in this kind of research-based test across individuals, so much so that getting a norm is hard. And even across the same individual over time, so much so that, if you scan a person and have them do a language test or something kind of higher order, like let's say a decision-making task, which kind of involves a lot of brain regions. The individual might use different tactics each time. You don't really know what's going on in their head in order to kind of perform the task. And so there might be variability from one scan to the next, even in the same individual. So saying that an abnormal scan, even if it was different than norms, at this time point is diagnostic of a condition that we're going to doom somebody with and treat them with the technology's not there yet. And so, one idea would be to get really standardized, very specific tasks to light up only, a few key regions that tends to light them up about as much in all individuals of this age and shouldn't really change over time for a healthy person, and use that task and use that bold signal, that fMRI signal, to diagnose some abnormality.
Right.
We're just not there yet.
But where they're at a research standpoint,
Yeah,
right? Where
at a group level.
At a group level, we're starting to notice certain things on the fMRI that maybe are starting to correlate with specific symptoms.
Yeah, certainly that's been going on for a long time. It's just that when you look across the studies even, and I can speak more to this with another form of fMRI that doesn't involve a task, which I'll talk about in a few minutes. But if you look across studies, there's so much variability across studies, and that calls back to the fact that concussion in an individual is so unique.
Yeah,
it's the pre-existing stuff, it's the mechanism of the injury, and it's the post-injury kind of circumstances that really quantify and characterize that individual's altered brain function. Right. If there even is an altered brain function, and some people, they recover quite well. Yeah. So I think looking at memory performance or decision-making or math ability, during an fMRI in a group of individuals in Iowa versus in LA versus, a civilian population that's primarily sport-related concussion, or a military population primarily blast exposure, you're going to get a lot of different fMRI responses. Right. And in some cases, you might get overactive, same regions, but overactive as compared to healthy controls. And in other situations, you might get, underactive. And it also depends on the analysis techniques, because it's this complex physiological signal that you're breaking down and kind of cleaning up and getting all the noise out of. And so it's just not there. And even at the group level, even if we find abnormalities, they can go one way, overactive, or the other way, underactive, across studies, looking at, similar populations.
So what is this other kind of MRI, this other kind of fMRI that you were talking about? Then?
Yeah, so I'll tell you about that. And it is fraught with all the same weaknesses, but there is kind of this one niche in it that may translate to individual targeting for brain stimulation techniques, which is why I'm interested in it. But that's called resting state fMRI. Right. And so by definition, an individual who's getting that type of scan will rest. Not perform a task. They could be thinking anything they want. They could be doing mental math if they want. But we look at in resting state the slower fluctuations in blood flow across the brain regions, not the faster activities that are related to the speed of thought and doing kind of mental math and other tasks. And so underlying that is this slower fluctuation, and it tends to occur in brain regions that have structural connections at the same time. So two regions that have a structural connection tend to have a blood flow increase and decrease at the same time. And so if you gather data across 8, 10 minutes, 15-minute period, and you look at the correlated blood flow across brain regions at rest, you tend to pick up regions that kind of light up together and go dark together.
That are not task-based. It's just someone just sitting there, not doing anything.
Exactly.
But would the idea be if they're, obviously we're talking about concussion and traumatic brain injury and potentially even PTSD, right? So someone that you're saying someone already at baseline would have like this increased sympathetic tone maybe from their concussion, or, just hyper aware, right, from their PTSD. They might have sort of that increased signal at rest between these two regions in the brain.
I wouldn't put it that way per se. So, I think what you want to do is figure out which brain regions should have correlated blood flow. Let's say, again, the two memory centers, the hippocampi, there's two of them, one on each side of the brain. They should have correlated blood flow. And the more correlated the blood flow, meaning the more times over that 8-minute scan that they have, and the kind of more in lockstep they have increases and decreases in blood flow, the better memory performance that individual has. So over individuals, those who have more connectivity or correlation between blood flow between their hippocampi, they tend to perform better in memory tests. And so it's likely that having more correlated blood flow in areas that should have anatomical and kind of functional relationships will have, will kind of indicate better performance of a function that that circuit is involved in. But it's also true that a hyperconnected circuit, or regions that are correlated in blood flow over time that maybe normally don't have that strong of a correlation, that could also indicate not an improvement in function, but worse function or more symptoms. And so again, we end up with this interesting question of increased or decreased connectivity in this case, not task-related activity.
There's a sweet spot for connectivity. That's what it seems like. Well, that's what it might be.
I think.
What's the right term, man?
The reality is that there's an increase that, depending on the disease population that you look at,
right?
An increase could mean something good or bad. A decrease could mean something good or bad. So what you try to do is study the same population across multiple sites and across multiple studies and find the same direction of finding, barring that all the methods they used was the same.
So give an example of I can already think of an example. Give an example of increased connectivity, in someone being a bad thing.
So let's say from the amygdala to some portions of the prefrontal cortex. Mm-hmm. Those regions are known to be very interactive. If you look in animal models, there's a dynamic relationship between the activity in those two regions that probably has something to do with emotion regulation.
Right.
So the prefrontal cortex probably both amplifies activity and dampens activity in the amygdala, and together that dynamic role is involved in fear learning, but also reward seeking and autonomic control, and a plethora of other kind of affective or emotional and social functions and behaviors. And so the dynamic relationship between those two structures can be disrupted in certain conditions. Let's say oppositional defiant disorder is a neurodevelopmental condition. And so it's found that in that population, the connectivity is increased in resting state fMRI. Mm-hmm. Whereas in healthy adults, I found in one of my prior studies, connectivity between the prefrontal cortex and the amygdala is increased in people who have larger social networks. Mm-hmm. Purportedly a kind of you'd assume like a positive thing.
The more popular kids in high school. The more popular kids in adulthood.
Yeah, this is more kind of having a more rich social network, and it's not that study was not in Facebook or any of the online stuff, but in real world social networks.
Yeah.
But essentially, in a younger population or a different age population, and or in a different kind of group, healthy or some specified disorder, the relationship between the connectivity and symptoms could be different.
Right.
And so in some cases, hyperconnectivity might be good.
Yeah.
In some cases, it might be bad.
Right.
And so I think, arriving at that understanding and then really kind of pushing to find multiple scenarios where that type of connectivity using the same methods is popping up and is predicting symptoms,
right?
Then you're starting to outline this endophenotype.
You're standardizing these abnormalities, whether it's hyperconnectivity between different areas of the brain or hypoconnectivity, to diagnoses and clinical symptoms. Right. So that's just to say, resting state fMRI is not in its infancy, but still needs some work to do before we go and translate it into standard of care.
Yeah.
Right?
Oh, yeah.
More
definitely.
research.
Definitely more. It's just like the task-based in that you're not using resting state on an individual subject basis for the same reasons. It varies across scans, right, even in the same day, let alone several days in the same individual. And it varies across groups, as I was just describing, even if they're the same type of group, like healthy controls of a certain age.
So how does it apply? Because I want to get to this. How does it apply to concussion and what you're doing?
Yeah. So I think the interesting thing about resting state fMRI is that it harnesses information about the functional relationship between brain regions that tend to have anatomical connections. And so it's trying to get at, I like to say, kind of a team of brain regions. And so if that team, like a basketball team, is in sync, they're functioning optimally, they're kind of up together, they're down together, and when one member of the team is down, the other people can be up. And so that dynamic relationship, being up and down and kind of asynchronous when needed for the demands of the situation, just like heart rate variability, this dynamic ability it might tell you something about the function of those brain regions and the kind of optimal set point for a particular behavior. And then when you find that, you can look at, is that abnormal in concussion?
Right.
And so there's about there's hundreds of studies, but about 50 or so that actually looked at the networks of the brain and how they were altered or different after concussion versus a similar cohort of patients that had no concussion. And again, none of these studies have pre-concussive imaging, so we can never say before the injury their brain was normal, after the injury. So you don't know that the brain changed due to injury, but you just know whether it was different or the same as a healthy control group. And so what I can say, which is interesting and it's a little bit of a letdown, is that across kind of the 7 typical networks that are looked at in the brain, there's a huge variability across studies as to whether there's an increase in connectivity, a decrease in connectivity, or no difference across all the studies. So let's say looking at one of the most classic networks where that's involved in kind of thinking about the past and projecting about, what one is going to do in the future or what one might feel in the future. This kind of default mode network that's kind of always going on in the background. It's the most popular network that's talked about and studied. Of the studies that looked at that, literally half showed an increase in connectivity in concussion, half showed a decrease in connectivity, and half showed no difference from control groups across 50 studies. Yeah. And so, a third in each of those groups, I should say. And so the problem is, were the methods different between those studies? And that's what caused the difference? Was it that each of the groups that were studied was a little different because their mechanism was different and so on? Some of them were military, some of them were civilian populations. Was it the demographics, the sex of the individuals? And so we looked at many of those variables, the age of the individuals, and we couldn't find one that really described why the studies varied from increase to decrease to no difference. So it makes this technique kind of in its infancy in that respect, but also begs the question, what networks are we looking at? How are we looking at them? And what should we hypothesize, in terms of kind of brain anatomy could be affected? Right. And so that's why going back to the endophenotype concept and autonomics and kind of emotion and kind of behavioral regulation, which all fall into common symptoms after a concussion, would make us think there must be this kind of frontal emotional circuit abnormality that's involved in some patients. Right. Maybe there's an abnormality that causes some autonomic dysfunction or some anxiety or some dysregulated behavior or emotion, some disinhibition, some impulsiveness, some kind of depression. Maybe that abnormality is also involved in some kind of dysregulated chronification of pain, maybe fear avoidance and things like that. Yeah. And so the circuits of the brain that are involved in those dysfunctions really have to do with those kind of ventral and medial prefrontal structures, and we can show a picture of that with the amygdala. And so in my work, I hypothesize that those regions are abnormally functioning. And what I've found so far in preliminary data that's unpublished is that there's a hyperconnectivity and resting state between those regions. And so, and that's across several different studies of different populations with different age groups, different mechanisms of injury, which begs the question, is there an endophenotype here that we can target? And it wouldn't be...
with this, noting this hyperconnectivity, exactly. Is there an endophenotype to that hyperconnectivity?
Is an endophenotype? Is the hyperconnectivity an endophenotype?
Right, exactly.
Is it a targetable abnormality in some people after concussion that is predictive of chronic symptoms, and therefore, if you were to target that
predictive of a certain constellation of symptoms after concussion, that would predispose you to developing persistent post-concussion symptoms.
Right.
Is that right?
Yeah, I think there's also another interesting question that we're kind of starting to get to, and it's is there at least some common mechanisms that underlie the plethora of symptoms? One idea is to take clusters of symptoms and ask what is the specific mechanism and then treat that, as we did with autonomic dysfunction, and we treat it with those different techniques we talked about. The other idea is there a common psychological mechanism, kind of neuropsychological mechanism that underlies why people have the varied symptoms that otherwise don't map back to one brain region,
Right.
or the brain region that was hit, or the kind of brain region or circuit that was kind of affected in the mechanism of the injury.
But that doesn't necessarily matter, right? If you can identify a circuit that's hyperconnected that potentially you can target, right? That correlates with certain symptoms after a concussion, right?
Well, I guess the reason I'm bringing it up is that if you were to map multiple symptoms, the post-concussive symptom cluster,
Right.
that don't necessarily map back to any one circuit, but that have a relationship to hyperconnectivity in this one circuit,
Yeah.
You would then ask, well, why is it this one circuit? This one circuit's not in charge of all these symptoms.
Right.
This one circuit has nothing to do with, let's say, math or dizziness or cognitive fog necessarily. But maybe it's that one circuit's involved in a coping mechanism that goes abnormal in some people, and therefore produces or enhances, exacerbates, as a force multiplier to produce a lot of these kind of vague and seemingly unrelated symptoms.
Right. But I think that if we do that, we're falling back into the thing, Occam's razor's concept, right? Where it's like, does this hyperconnected circuit explain all of the persistent post-concussion symptoms? And it might, but it might not. It might just be a significant contributor. But nonetheless, right, if we're able to find out, hey, this is the circuit that's hyperconnected, that's really, really contributing to people's persistent post-concussion symptoms, then potentially we can target it.
Yeah, no, so I agree with you. And, what we're talking about is kind of symptom mapping. I'll just make one more, kind of reference to resting state fMRI and fMRI in general.
Yeah.
One idea is to compare groups, control healthy individuals that are demographically and age matched to the concussed group, and look at the resting state connectivity or the bold, fMRI task-based activity, and say something is different than controls. And that's one way to look at it. The other way to look at it is across individuals in one group, in the concussed group. Do individuals with higher connectivity have more symptoms of a particular class or globally or whatever? And that's called symptom mapping. Right. And so if we map symptoms to a circuit or network or a brain region, you can then do that in that group and several other groups without using a control group necessarily. It doesn't mean that connectivity is different than controls. It just means that in the individuals with the most extreme connectivity have the highest amount of symptoms.
Right.
And if that connectivity difference tends to fall in the same set of regions across studies, you start to think there's a mechanism here that's underlying chronic symptoms.
Right.
And that symptom mapping approach is somewhat new, and it's allowing us to use resting state data sets, even after they've been collected, to map symptom clusters to, and then figure out if there's kind of vulnerable networks, even if they are no different than controls per se, based on their raw numbers, that the connectivity profile correlates with specific or even broad sets of symptoms. Right. And so that's the approach that I'm starting to take, because, as I said before, there's so much variability cross study in the healthy group, control group, versus the concussed group. And so you may not find a difference, but if you map symptoms to a circuit and then show that that's replicable across studies, you might be hitting on something. Yeah. So anyway, the way to target, and I think...
let's get to it. Yeah. Transcranial magnetic stimulation.